Hello, everyone. My name is José Eduardo de Aguilar Nascimento, and I'm here to talk today about preoperative fasting period. This is my second invitation to participate of the Post-Pain Congress, and I'm very honored and happy to be with you in Poland. Well, my task today is to talk about reducing of preoperative fasting period. And I would like to show to you my disclosure and say that back in 2005, we have implemented in Brazil a multimodal perioperative care protocol named the ACERTO project. It was based on EROS protocol and also in the studies made by Kellett and Wilmore back in 1980s when they present to the world a new strategy of reducing perioperative days, and they call it fast track. So in Brazil, we have been 15 years of experience with the support of the Brazilian Congress of Brazilian Society of Surgeons and the Brazilian Society of Parenteral Nutrition. And this publication, we show the history of this implementation here in Brazil. One of the prescriptions of the multimodal protocol is the fasting period, both preoperatively and postoperatively. And today I will talk about reducing preoperative fasting time, which is one of the issues that I have more written in the past years and published here in Brazil or in other parts of the world. What does ACERTO means, the ACERTO project? ACERTO is an acronym of Enhanced Recovery After Surgery, which can be pronounced in Portuguese, Aceleração da Recuperação Total Pós-Operatória, which means enhanced recovery after surgery. But at the same time, acerto is a strong word in Portuguese, meaning do it right or hit the target. So it's a good word for a changing protocol of perioperative care in Portuguese, of course. So, as I said, we have been supported by the Brazilian College of Surgeons and the Brazilian Society of Parenteral Nutrition. And together we have been publishing some years ago a guideline of perioperative nutritional interventions in elective general surgery, which was called the ACERTO guidelines. And we discussed on the protocol and in this guideline about the changing from traditional preoperative fasting time of 6 to 8 hours of absolute fast. And we joined the group of researchers and societies that are changing this for a new modern preoperative fasting time. I recommend to everyone to read this article written by Maltby from Canada. And in this article, he tells us the history behind the dogma of prolonged preoperative fasting that we have been seeing around the world in the last decades. Well, there's a rationale for staying a long time in fast, and it was prescribed to avoid regurgitation and aspiration of gastric contents into the lung or into the airway during the induction of anesthesia. The problem with this protocol that it was imposed after a retrospective study, not in elective general surgery patients, but in parturients, which is a different type of patients, of course. It was, this paper was published just after the World War II, 1946, after a retrospective study, as I said, in labor patients. And Mendelssohn, which was the first author of this paper, showed some cases of lung aspiration and 2 cases of death in a large retrospective number of patients. And well, this changing of protocol was adapted to be prescribed in general surgery in elective patients. And it was shown to be very easy to prescribe, just new per month after midnight, and very easy for patients to understand. So because of that, this protocol has been so popular around the world. It was very on the opposite side that what was seen before. You can see in this book written by Joseph Lister that no solid food was allowed to be ingested when you see chloroform. That was the time that anesthesia was done with chloroform, was prescribed. But for Lister, it was very salutary to give a cup of tea or a beef tea about 2 hours before the induction of anesthesia. And you can see in this publication of a sequence of anesthesiologists' guidelines of perioperative fasting that after 1955, there was a changing from 2 to 4 hours of fast with various different kind of fluids like tea, beef tea, juices, to new per os or nothing by mouth after midnight, or a minimum of 6 hours in the following years in these guidelines. However, it's important to understand that human perception is not equal to what is happening in day by day. What I mean is, when you prescribe 6 to 8 hours of fast, patients usually stay much more number of hours waiting for surgery. In our hospital, we audited a series of patients back in 2005 and could show to the hospital that when we prescribed 6 to 8 hours of fast, patients have a median of 16 hours of fast, with patients staying sometimes 24 hours of fast waiting for surgery. This was awesome. And we published this for the first time in Brazil in 2006. This was followed by a new question. Is that happening only in my hospital, or is that happening in other university hospitals in Brazil? So we joined a task force and we designed a study, a multi-center study, comprising 19 university hospitals in Brazil. The name of this study was the Big Fast Study. And we could see in thousands of patients that what was happening in my hospital was happening all over the country. Most of the patients which receive a prescription of 6 to 8 hours stay longer than that waiting for the surgery. And you can see that about half of the patients stay more than 12 hours of fasting, which you can see that metabolic, in a way of thinking, this patient had not a good metabolic status to be operated on, to suffer a programmed trauma, such as an elective surgery. We all know by literature that prolonged preoperative fast is associated with an increase of insulin resistance, increase of inflammation. Both of these consequences can increase after the trauma, after surgery. And prolonged perioperative fasting is also associated with increase of nausea, vomiting risk, and adverse symptoms like thirst, hunger, irritability. And the consequence of all this is a much more increased length of hospital stay. So we can say that insulin resistance is the main cause of postoperative hyperglycemia. And hyperglycemia per se will increase the postoperative complications, increase of catabolism, nitrogen loss, lean body mass, which will interfere and impair early postoperative mobilization. That's what we want postoperatively. In the other hand, 2 hours of preoperative carbohydrate-enriched solutions is very safe in many studies, in many meta-analyses. And patients can arrive to the surgical theater not only more hydrated, but also with a normal metabolic status. And there is no reason to believe that this increase pulmonary aspiration if the patient regurgitates gastric contents. There is no any randomized trial that is associated the abbreviation of preoperative fast with this kind of accidents. Well, all these societies of anesthesiologists around the world has a common sense in their recommendations for a 6 to 8 hours of fast for solid food, but clear fluids can be allowed until 2 hours before the induction of anesthesia. Some more modern societies, they express that this clear fluids has to have carbohydrates, especially maltodextrin, which is a complex carbohydrate and much more useful in this prescription. The Brazilian Society of Anesthesiology, in the last review of 2019, also agree with that. And the level of recommendation for the use of maltodextrin at 12.5% in a volume of 200 to 400 mils is strong, as you can see here. Our first guideline was this, which is present in this slide. We fast patients for solids for a minimum of 6 hours. The night before surgery, we gave them 400 ml of a beverage containing maltodextrin, and we repeat this 2 hours before the initiation of the surgery. So this is the protocol, and we have been seeing that in Poland, you have this product, Carboc, which has maltodextrin, and you can use in the same way that we are saying here, diluting 25 grams of Carboc in 200 mils of water to give this 2.5% of maltodextrin in a solution for the patients to ingest, to drink. There are a lot of benefits associated with that. We can say that, first of all, is the recommendation of various international societies of anesthesiologists. It increases before surgery the liver contents of glycogen and blunt postoperative increase of insulin resistance. This is very important. It decreases the risk of nausea and vomiting postoperatively, and some papers looking at patients submitted to major abdominal surgery, that the length of stay can be decreased up to 1.5 days. And all other reports with statistical analysis show that this changing this prescription of abbreviation of preoperative fast is a major independent predictor of reducing adverse symptoms such as nausea, vomiting, pain, diarrhea, dizziness, and some complications like wound dehiscence. There are limits, of course, for the prescription of this abbreviation of FAST. One of the limits is when the patient has some kind of intestinal obstruction, some difficulty in emptying the gastric contents, like what we see in gastroparesia, when the patient has gastroesophageal reflux, and when the patient was submitted before to a gastrectomy or to a gastroplasty because of the reduced gastric stomach. And there is no much evidence that this is appropriate for patients with decompensated diabetes mellitus. This is the first publication of our anesthesiologists back in 2009, and the first 375 patients, they look at to see if this was safe, and there was no complications related to this changing of protocol. Nowadays, we have thousands of patients being operated with this protocol during the last 15 or 16 years, and there was no one case of bronchial aspiration, regurgitation, pneumonia with the changing of protocol. We could see that even in procedures, not major procedures, but for instance, hernioplasties, video cholecystectomies, the changing in the metabolism of serum glucose was a pattern. You can see here in dotted blue lines that the level of serum glucose preoperatively and postoperatively stay more normal in non-diabetic patients submitted to video cholecystectomy. And the cause of this was, of course, the better insulin resistance associated with this protocol when compared with traditional protocol. This meta-analysis shown that when we use a carbohydrate load 2 hours before surgery in major operations, abdominal surgeries, we reduce the length of stay by 1 day, which is one of the best application, best recommendation for this changing of protocol. We have been compared what we had before the traditional protocol, and some years after we introduced this new protocol in thousands of patients, and the whole protocol was seeing that we could significantly reduce the surgical site infections, postoperative complications, the need of reoperation, and even with these thousands of patients, we achieved a decrease in mortality in our infirmary. And we have been using this protocol not only in general surgery, but also in some types of surgery, such as surgery for the obesity. And this is the pilot study. We have published other studies, but this was important. It was a randomized trial. And we could see that obese patients can receive this protocol with safety. No accident occurred during the anesthetic procedure. And more than that, we could reduce 1 day in patients that receive this protocol of preoperative fasting of 2 hours. Nowadays, we have the Acerto project being used by a series of authors in Brazil. This was a group that made analysis of 15 studies in elderly patients after hip replacement surgery. They comprise 1,225 elderly patients submitted to the Acerto protocol. And you can see here that there was a decrease in preoperative fast after the changing of protocol, of course, a decrease in the time of postoperative refeeding. And the consequence of that was that the days of hospitalization, the length of stay, was reduced after the changing of protocol in the same type of surgery, in the same hands of the same surgeons and anesthesiologists. We have seen this in many specialties in surgery. We are showing here our first experience in pediatric surgery, and you can see here how we reduce preoperative time in this type of patient in children with safety. And along the years, we have been auditing the changing in this country, supported by the Brazilian College of Surgeons and by the Brazilian Society of Parenteral and Enteral Nutrition. And as you can see here, from 2015 to 2019, there was an increase of adherence in the protocol of 2 hours fast using maltodextrin, an upside of more than 150%. So, as I said during all the presentation, prolonged fast preoperatively must be avoided by all means. The second final consideration is that perception is not equal to reality. The number of hours of fast is usually greater than the number of hours of fast prescription. And this beverage containing carbohydrate, maltodextrin, can be prescribed for most elective patients with SAFE. It's not only recommended by various international societies of anesthesiologists guidelines, but it's also associated with benefits for patients, including less postoperative symptoms and a reduced length of stay. That's why we stress that surgeons and anesthesiologists should strongly promote the use of preoperative carbohydrate-enriched beverage as a strategy to enhance recovery after surgery. Well, this is my last slide, and I would like to thank once again ProDiet for helping me to do this presentation, and thank again the Polish Society of Parenteral and Enteral Nutrition for this kind invitation to be here again. Thank you very much.